OK ですか？ Hello to all dentists around the world. We are a group called Central Dentistry of Japan. Thank you for participating in this meeting. First, I would like to briefly explain the purpose of this meeting. Since last year, the world has been in turmoil due to COVID-19, especially in Japan. It is still difficult to go abroad easily. However, since we are dentists, we cannot stop learning. Fortunately, we can communicate with people from all over the world by using meeting service such as this Zoom. We would like to actively communicate with ambitious dentists from overseas. Let's become friends. All dentists are welcome. In the future, we would like to organize dental discussions, joint meetings, and lectures by famous speakers with groups of dentists from overseas. More information will be posted on our group page on Facebook. Please subscribe to our Facebook group page as well. We are very happy to be able to communicate with you using Zoom. This is just a short presentation to introduce ourselves, but we hope you enjoy it. Let's share the wonderful world of dentistry. Thank you. Please post your questions and answers in the chat section. We will post a summary of the answers on our Facebook group page later. Okay, let's get started with our first presentation.
Nagoya City, Aichi Prefecture,
Hello everyone. Today I will give a presentation on adhesive dentistry can save the teeth. The name of our team is Central Dentistry in Japan. My name is Shinya Ida. I am working as GP in Japan. I try to preserve teeth without extracting as much as possible. I am especially interested in adhesive dentistry. So I have been learning from many great dentists. A lot of knowledge thanks to them. You can see many of my cases on Instagram. Please take a look. Here is the exterior of my dental clinic. It is located in Nagoya City, Aichi Prefecture, in Japan. Let's take a look at the world map. Japan is here. We are sending out a message to you from here. We want to communicate with dentists all over the world.
Hi. 还没开始啊，陈信来听吧。你现在那个荧幕的网络，那个电脑的，你把你的热点关掉吧。今天好像，对，好像是连你的。
I am working as GP in Japan. I try to preserve teeth without extracting as much as possible. I am especially interested in adhesive dentistry. So I have been learning from many great dentists. A lot of knowledge thanks to them. You can see many of my cases on Instagram. Please take a look. Here is the exterior of my dental clinic. It is located in Nagoya City, Aichi Prefecture, in Japan. Let's take a look at the world map. Japan is here. We are sending out a message to you from here. We want to communicate with dentists all over the world. Okay, now there are 4 important aspects of dentistry: biology, structure, aesthetics, function. How would you treat tooth loss due to decay or other dental problems? In this presentation, I will focus on adhesive dentistry. Look at the diagram here. A healthy tooth decays and is treated. The tooth is decayed over and over again. Then a root canal is needed. A crown is placed, and then another cavity or fracture occurs. And finally, the tooth has to be extracted. Once tooth is in this cycle, there is no escaping it. However, with the help of adhesive dentistry, the life of the teeth can be prolonged with good treatment. First of all, let's talk about direct restorations. I will show you the purpose of direct restorations: minimally invasive intervention to remove caries, and the proper bonding operation, a certain marginal blockage, aesthetically good morphological recovery. Let's look at a case study. The patient had caries on bicuspids. Isolation was done, and composite resin filling was done with proper bonding techniques. Here is a similar case in molar. The morphology mimics natural teeth. In anterior teeth, diastemal closing with composite resin is also effective without removing tooth structure. And large fillings can be achieved with an understanding of tooth morphology and color reproduction. In this way, direct restorations can preserve the tooth structure. The next step is indirect restoration. I rarely do full crowns these days. Most of them are partial crowns that preserves the tooth structure. Left side, inlays are at risk of fracture at the marginal ridge. A full crown removes a lot of tooth structure. A partial crown reduces the risk of fracture and preserves the tooth structure. I refer to this literature here. Also, according to this article, composite resin is better for bonding lithium disilicate and has a much higher bond strength than routine composite. Immediate dentin sealing is also important. This is the process of bonding the tooth surface prior to impression. This step. This will dramatically increase the bond strength. The bond strength of OptiBond FL is particularly remarkable. That's why I use these products in my bonding operations. OptiBond FL, composite resin heater EnerHeat, and direct composite by Michelin. Isolation and bonding only with lithium disilicate. The last case with direct restoration and indirect restoration is shown below. The patient was suffering from dental malpractice and was looking for an aesthetic improvement. So first of all, I replaced the old crowns with provisional. First, provisional restoration. Orthodontic treatment was performed. Teeth aligned and tidy. Then, the dental technician did the workup. The morphology obtained from this was made provisional restoration, second provisional restoration. This is second provisional stage. Patient lived with this condition for a while. After that, a further workup was done to simulate a form close to the final form. Diagnostic workup, third provisional restoration. I filled the palatal site of the canine with composite resin in order to obtain canine guidance. The third provisional restoration is now in place. The old small restoration was replaced with composite resin filling. Impressions were taken. The final prosthesis was made of zirconia and lithium disilicate. The partial crown was made with lithium disilicate to preserve the tooth structure. The prosthesis needs sealing and bonding. Tooth needs cleaning and bonding. I use composite resin for routing. Similar step, upper molar teeth, labardum isolation, enamel etching and bonding. Routing with composite resin. And 31 and 22 between diastema closing with composite resin. The final state, compared to the preoperative state, there is no new intervention on the tooth. Close-up of the anterior teeth and lips. The aesthetic condition has been improved. You can see that it is now in very good condition. Comparison of before and after. The patient was very happy. Conclusion. Adhesive dentistry has made it possible to preserve more tooth structure than ever before. I would like to contribute to the health of my patients by preserving their teeth as much as possible. This concludes my presentation. Thank you for watching.
Hello, everyone. My name is Shogo Ando. I'm so happy to have the opportunity to share with you my presentation during this wonderful meeting. Today, I will talk about a multiple implant-supported occlusal reconstruction case study, while taking advantage of the complementarity of digital and analog technology. And nowadays, as some of you might know, Japan is becoming an hyper-age society. According to a national survey conducted by the government in 2016, more than 40% of Japanese patients with 80 years or more had 20 or more teeth remaining. Also, this condition is rapidly increasing. You can see in the following graph how there's still a very high amount of edentulous patients. Currently, in cases of edentulous ridges or missing teeth, there exist multiple options such as implant bridges, bone-anchored bridges, overdentures, or even the conventional complete dentures. There are advantages and disadvantages for each of those. But when considering mastication and biological cost, implants represent an excellent prosthetic option. When it comes to implant indications, it exists the McGill consensus for the lower jaw. While there's not such a protocol for the upper jaw so far. A systematic review made from 2010 to 2016 defined 6 implants or more as the ideal amount of fixed type implants for the maxillary arch, while for implant over denture. It is said that as long as 4 of 6 implants can be placed in parallel, 4 or more implants would be enough to support an overdenture. In patients with full or partial edentulous arches, the total rehabilitation might look very complex. I designed a treatment plan based on these 5 factors needed for an ideal occlusion, focusing on desirable treatment results in terms of aesthetic and function. These factors apply for every patient. Among them, the one that takes the longest time is the correction of the jaw position, which is the key condition for an ideal occlusion. The conventional method consists on selecting the material, preparing the model, creating a diagnostic workup, inducing the correct jaw position, preparing the provisional restoration, and repeating the workup. From this point, the restorative-driven treatment is repeated over and over, finally leading to an accurate goal. However, with the invention of digital method, it is possible to simulate the blueprints in a digital way. In other words, cephalography, CT, and models, and digital materials and analog materials are combined digitally. And they can be used to determine the placement position of the implant, as well as to correct the jaw position and to make the prosthetic design. It is possible to shorten the treatment period and reach the desired goal, which will lead to the long-term stability of the implant itself and its superstructure. I would like to present 2 cases of occlusal reconstruction using this digital simulation. First, this is a case with fixed superstructures. The patient is a 64-year-old woman. There was no any particular medical record, but she showed discomfort related to her dentures at the time. Regarding the treatment plan, in this case, the patient didn't want to use dentures, and she also didn't want to get a GBR treatment. So we decided to place a substructure as for the maxillary arch. And for the mandibular, it was possible to conserve the anterior region, so we proceed with the posterior region by planning the use of implant-supported bridges. We will proceed with the treatment plan as we review the 5 necessary factors for a proper occlusal reconstruction. First, we must define the vertical dimension. To define the final vertical dimension, first we define the distance between A point and B point, and we trace a Gothic arch and record the tapping points. After setting the vertical dimension, we place a clear acrylic radiographic guide and we do the digital simulation. First, we determine the placement position in the mandible. In the mandible, it is necessary to place an implant in location 6. And thanks to the digital program, both the cephalography and the plaster models can be combined. It is said that the line which connects the Killich point and the antigonial point represents the location of the master muscle, and that the line traced perpendicularly passing through Killich point and forming 14 degrees towards major would be the ideal position to place number 6 implant, as it represents its inclination towards major. To set the inferior incisor edge position, we define a point 18 millimeter away from the B point. Then we trace an imaginary occlusal line through the retromolar pad. And following this, we decided the implant position after antigonial point and Killich point. And next, we perform the digital simulation for the upper jaw. The position and inclination of the anterior maxillary teeth are determined naturally once we define the position of the mandibular teeth. In this case, in order to bring the maxillary anterior teeth to an ideal position, a GBR treatment was necessary. But the patient didn't request a GBR treatment. The implant placement in the original bone was given priority for this time. We prioritize to place all implants in patient's original bone, and we determine the placement position by taking into account the inclination at some extent. However, we place number 3 and number 6 implants in a parallel position so that it can be easy to put and remove the implant over denture afterwards. Then, after finishing the digital simulation, we place the implant and proceed to do a clinical crown lengthening for the mandibular remnant teeth as we conserved. Finally, once that osseointegration has been achieved, we proceed to create the provisional restoration. From now, we will see how to define a proper jaw position. And Dr. Sia, who is a Japanese dentist, image diagnosis to obtain the gap between the condyle head and the glenoid fossa. As you can see here, the left temporomandibular joint is over the ideal position. We will define the anterior guidance. To determine the anterior guidance of the superstructure, we measure the sagittal anterior angle using an Axipus recorder and measure the sliding distance of the condyles. The eminence for this patient was for both sides around 42 degrees, but sliding distance of the condyle head on the left side was shorter. And an imbalance was slightly observed during the lateral opening and closing movement. Same as deviation during the protrusive movement. The condyle is caught at the lateral opening and closing movements. And the polarization on the left side is admitted when the protrusive movement is seen. The major deviation of temporomandibular joint is corrected on the articulator using a repositioning appliance and by delivering a provisional restoration. We check in the oral cavity if there is any functional problem. Compared to the previous movie, it can be confirmed that jaw movements can be performed in a good way. As you can observe here, Position of the temporomandibular joint and the distance of the gliding is in a normal value. And finally, we will deliver the final restoration in order to reproduce a stable, mutually protected occlusion. These are the delivery day of the final restoration. As you can see, mutually protected occlusion is correctly respected and the occlusal points are adjusted as much as possible. So the jaw position and function are well maintained. This is the situation before treatment. And this is after treatment. And results were satisfactory in terms of aesthetic and function. Here is the next case. I'll introduce a case with removable superstructures. In this case, patient is a 64-year-old woman. She came to my clinic complaining about a misfit in her two dentures. She had a previous history of vomiting reflex, reason why she was using a palatal denture supported by a single tooth. But afterwards, finally, she lost her only superior remaining tooth, losing at the same time the retention for the maxillary denture. She also was unsatisfied with her previous mandibular denture, reason why she stopped using it. Because of her vomiting reflex, she asked for a palatal denture. This is a treatment plan. The patient was not particularly dissatisfied with removable dentures. So we planned a maxillary palatal overdenture and a mandibular implant-assisted removable partial denture that can give support and stability. So this time as well, we will check the 5 necessary factors for proper occlusal reconstruction. Then we prepare a Gothic arch tracer with an average distance of 38 mm between A point and B point and define the vertical dimension by the position where the tapping point was stabilized. In the position, we make a template for the CT. We start with the maxillary digital simulation. Implant placement position in the maxilla was designed in order to be perpendicular to the occlusal plane and parallel to each other in location 4 and 6. Since the main objective was to create a palatal overdenture, we selected a flexible type implant overdenture, and for the abutment, we choose a locator type. Next, we plan the mandibular digital simulation. The patient is 64 years old, still young. It is necessary to think about the biological cost. We planned an implant-assisted removable partial denture, and by enlarging the fulcrum line, we can pass from a Kennedy class 1 to a Kennedy class 3. The implant placement site was designed for both sides in location 6. And next, we designed the framework. Attachment design is meant to only give retention and prevent dislodgement. And we designed the denture with a root-like shape I-bar parallel to the guide plane of the major slope of the denture to make it easy to insert and remove it. The framework of the implant overdenture has a reinforcing structure and it covers upper part of the abutment. It is said 3-dimensional reinforcement structure would be necessary in order to design properly the future appliance. The direct maintenance device was designed to resist the rotational forces applied to the abutment tooth by the implant assisted removal partial denture with respect to the lower jaw. We designed a RPI, including a proximal plate, in order to strongly resist the rotational forces. So we will proceed following the 5 necessary factors for a proper occlusal reconstruction. This time, we will define the proper mandibular position. We will correct the displacement of the jaw position, measures on CT, again with a repositioning appliance. When setting the appliance, it doesn't fit in this way, but after using this for 1 week, the jaw position will be corrected and proper jaw movements will become possible. Then we scan the repositioning appliance and replace it with a surgical guide. By using the repositioning appliance as a surgical guide, it was possible to apply functional forces firmly and operate without flaps. And minimally invasive implant placement was possible. This is the post-operative panoramic radiograph and CT. We can see that the implant position is satisfactory. And we will give proper and balanced occlusion with the final prosthesis. After confirming osseointegration, we will place the final prosthetics and check its function and aesthetics. Finally, we will make a final occlusal adjustment and maintain the appropriate function. This is the preoperative. And this is after. Results were satisfactory in terms of aesthetic and function. In this presentation, occlusal reconstruction was performed using different superstructure of fixed type and limbal type. By using digital simulation in these 2 cases, a treatment period can be shortened and accurate implant placement turns possible. However, not everything is fully digital. It's important to understand the advantages and disadvantages of digital and analogs. Their advantages complement each other's disadvantages. In other words, mutual complement is important. From now on, I believe this will lead to better results and long-term stability for the implant treatment itself. Thank you.
Hello everyone, I'm Hidetoshi Aimiya from Nagoya, Japan. I'm a general practitioner. Thank you for joining us an opportunity for this meeting. Now let's start. Today's theme is treatment strategy for defects. I'd like to present my version of treatment strategy for multiple teeth defects through one case. Especially, I focus on the long-term occlusal changes and countermeasures. The role of dental treatment in occlusal reconstruction is to improve the patient's quality of life. To achieve that goal, it is important to maintain stability and comfort over the long term. People 20 or more teeth have less medical costs than those with 90 or less teeth. Having healthy teeth, the food is delicious, the conversation is fun, and the facial expressions are rich. It leads to general health. This is a summary of this presentation. Treatment strategy to preserve the remaining teeth for multiple teeth defects. Second, denture manufacturing method that combines aesthetic and functionality. Dentists and dental technician communication to meet the wishes for patients. Third, recovery from the artificial teeth worn using artificial teeth using zirconia. Now let's start. At the first visit, look at the photo of the face. A deviation to the left of recognized. And 90, it have abutment teeth, swelling is observed. Strong speed curve is observed. Diagnosis, mandibular position is unstable. Maxilla, all teeth are missing. Mandibular fluid-ended defect. 90 and 41, difficult to preserve due to progression of periodontal disease. Treatment planning for anterior lower teeth is abutment teeth on single tooth. Is it connected? If the supporting tissue around the abutment is expected to regress or overload, it is better to perform articulation. Think about the patient's situation. I decided to connect with the crown and insert a free and end defect denture. Relationship between Gothic arch and tapping points. Gothic arch monofocal. Tapping point is not stable. Using artificial teeth with a flat occlusal surface, I decided the relationship between the upper and lower jaws. Use this denture to adjust the mandibular position. Comparison before and after treatment denture. The mandibular position changes by using a treatment denture, and the mandibular anterior teeth are located slightly posterior, and the temporomandibular joint is located slightly anterior due to clockwise rotation. Changes in facial appearance with treatment dentures. The tension in the face is improving. Comparison of movements before and after treatment denture. The jaw movement become stable. Second, cooperation with technician is important when making dentures. This photo shows a patient with a customized gingival sample. Dental technician Kainuma, who work with me, always does a good job. In 1910, we went to Swiss to study denture staining. First, the artificial teeth are arranged. Next, mix the denture staining material from candule. Place the cervical part, the attachment gingival part, and free gingival part in this order. Like this. And finally, added the base resin of the denture base and close the flaps. Close the flaps. Added the base resin of the denture base and close the flaps. Close the flaps. Precaution of denture staining. The main purpose of denture staining is to reproduce the loss of gingival morphology of the patient, and the function is fully organized. It is important not to have an unreasonable gingival morphology that prioritizes staining. It is a completed denture. I added denture staining. Porcelain fused metal with an extra crown attached is used for the anterior teeth of the mandible. I was able to resemble the patient's gingival color. Mandibular anterior teeth are connected. The attachment of the extra crown attached was stable.
このレベルのものがね、バリバリ食べれてしまうとすごく
He
いい
said,
ですね。
I can chew anything with confidence.
ああ。あれ、何でも食べてると余計ね、顎の筋肉と。
After 6 years, the situation is stable. But an artificial one was observed, not only on the molars, but also on the anterior teeth. I was adjusted anterior teeth. 10 years after, the artificial teeth one got worse. Changes in dentures in 10 years, artificial teeth one is observed. The patient's unique occlusal surface that she created over 10 years by herself. I tried to replace it with zirconia artificial teeth with CAD/CAM. Comparison of Gothic tracing between initial examination and 10 years after treatment. Stability of the jaw movement and settled. Tapping points are observed. Scan with the lab scanner, then designed by ExoCAD, like this. Zirconia artificial teeth have been created. I could reproduce the patient's unique occlusal surface created over 10 years. Being stable for wax denture trial. After confirming occlusion, then I polymerized it. Scan and made by zirconia. Fitting and function is good. Finally, not only functional, but also the aesthetic. Comparison before treatment and after 10 years treatment. "20 years has passed since the first visit, from 2008 to 2020. Improved balance of the left and right mandibles. 20 years has passed since the first visit." Conclusion. In the design of denture treatment, it is important to take a strategic approach according to the condition of the defect, the presence of the teeth, and opposite teeth. Artificial teeth and dentures are not permanent and require repairs of the dentures or denture base every 10 years. The digital scanning method was able to reproduce the morphology and follow the defects of artificial teeth made over 10 years. As a result, it led to increase of the QOL for patients. Treatment strategy, including long-term patient maintenance, are important factor for long-term stability. Thank you for your attention.
Hi everyone, my name is Taisuke Tsukiboshi. I'm talking about autotransplantation today. Let me introduce myself briefly. I'm working as a GP in Japan, Aichi Prefecture. I'm a member of American Academy of Implant Dentistry. So my specialty is implantology. I'm showing some cases about autotransplantation, which is using the wisdom tooth instead of placing implants. By the way, what is the autotransplantation? I want to share my case with video. Okay, so this patient was 37 years old when I performed the autotransplantation surgery. So this picture shows 1.5 years after transplantation. I replaced with wisdom tooth after I extracted number 47 second molar, which is hopeless to save. Okay, let me share with the PA, periapical X-ray. First one is immediate after post-op. Second one is 1 month after autotransplantation. So look at the PA. There is no bone distal part of the donor tooth. But after 3 months of the post-op, the bone healed about halfway of the height of the distal part. And after 1.5 years, we can see perfectly healing of the bone on the distal part and around the donor tooth. And we still can see some periodontal ligament space around the donor tooth. So, but if we want to achieve the successful autotransplantation, I think the case selection is very important. First one is age. Second one is donor tooth. Third one is the recipient site. Let me go detail. This article is published by my father, Dr. Mitsuhiro Tsukiboshi, 1999. According to his article, under 40 years, there's 93% of success rate. So I would like to say the younger, the better, but there is no limitation for the transplantation. Second one is donor tooth. We think about donor tooth, 3 things. One is a viable PDL. Second one is root shape. Third one is root formation. So, as you know, the viable PDL on the donor root is a critical factor for success. Root shape. Single root is more ideal for transplantation compared to multiple roots. And also, straight one is more easy to extract compared to the curved. But we don't know when we extract the donor tooth, there is PDL is saved on the root or not. So if the donor tooth is partially missing, partially missing PDL, the results will be 3 categories. One is replacement resorption. Second one is inflammatory resorption. Third one is surface resorption. The first two resorptions are actually unfavorable results of transplantation. But third one, surface resorption, is one of the healing. We notice this resorption only on PA. So we should take PA to follow the autotransplantation tooth. And I would like to talk about the inflammatory resorption, which is very complicated and important for understanding the autotransplantation. So if we extracted donor tooth, the pulp infection, the donor tooth is gonna get the pulp infection through the apex or decay part or excess adjustment, which performed by doctor. So condition of the donor tooth must be healthy tooth with intact enamel. The pulp tissue pressure is lost after extraction. Bacteria will be able to invade into the pulp space through the dentin tube. If there is exposed dentin due to the decay or excess adjustment of the enamel during the procedure, it causes of infected root canal and the inflammatory resorption. So if the donor tooth has pulp infection and the missing PDL, the results will be the inflammatory resorption. So inflammatory resorption is a progressive dentin resorption process in which a tooth with damaged periodontal ligament surface and the infected pulp transplanted or replanted. Radiographically, we can observe the resorption after 1 to 2 months after transplantation. If we see this kind of resorption, endodontic treatment is needed to cease progressive resorption. So once we find on the PA of the inflammatory resorption, we should perform the root canal treatment, and the goal will be the new attachment or ankylosis. So clinical suggestion, especially for we perform the root autotransplantation of mature tooth, we should do the root canal treatment within 2 weeks after transplantation. It's needed to avoid the inflammatory resorption. The last part of the donor tooth, root formation. I talked about mature tooth transplantation, but the donor is immature, which has incomplete root formation. So we can see clinically open apex more than 1 millimeter and with healthy weak epithelial root cyst on the top of the apex. So if we perform the transplantation of immature tooth, root canal treatment is not needed. On the other hand, like I show you, in mature tooth of transplantation, root canal treatment is needed. This is mechanism of healing of transplantation of immature tooth. If intact, healthy epithelium root cyst is seen on the apex, revascularization and root development will be expected. In results of a revascularization, pulp canal obliteration will be seen on the X-ray. this is a clinical case of the immature transplantation. Look at the before operation. There is a hopeless tooth on the number 46. They extracted and transplant wisdom tooth. This tooth is immature tooth, which has open apex. And after 2 years, 5 months, and 5 years, 8 months, we cannot see any root canal space, and which is healed with revascularization and the PCO, which is pulp canal obliteration. So this is the evidence of pulp healing. So, and then also this donor tooth reacted to the electric pulp test. So when I test with the electric pulp test after maybe 6 months, the donor tooth reacted to the electric pulp test. So still, like after 5 years and 8 months, the donor tooth reacted to our electric pulp test positive. So clinical suggestion: autotransplantation of teeth with immature tooth, incomplete root formation, offers the advantage of pulp revascularization and the re-innervation, eliminating the need for endodontic treatment. Let's go to the last part, the recipient side. So timing of transplantation after extraction of hopeless tooth. Like when we place the implants, it's divided into the 3 parts. So same as categorized transplantation will be performed immediately after hopeless tooth extraction or early or healed site. The first 2 is still existing, the extracted socket. The last one is already healed. So healed site means the hopeless tooth was extracted more than 6 months, and then the bone is healed completely. So I would like to say the immediate, just after extraction, is 1 day surgical treatment is a benefit. But the bad things will be the difficult to clean granulation tissue, and second one will be the inflammatory of the gum tissue. The third one is more size discrepancy between the recipient and donor tooth. Usually when the donor tooth is, we usually use the wisdom tooth, which is like smaller than the first molar or second molar. So there is more gap between the recipient site. On the other hand, if we perform the early autotransplantation within 4 weeks after extraction of donor recipient hopeless tooth, the benefit will be the easy to clean granulation tissue. The second one is no inflammation and more gum tissue. The third one is less size discrepancy between the recipient and the donor tooth. When look at the picture, after we wait the healing for like 3 to 4 weeks, we can get more keratinoid tissue, and there is no inflammation of gum tissue. So it will be very easy to handle when we perform the surgery. But bad thing is only for the patient is the second stage surgery. So patient gonna have twice surgery. And then when we look at the compared to the extracted site and the healed site, when we performed the autotransplantation for the healed site, we have to make a new socket with bar. According to the article, if we perform the auto-transplantation for the extracted site, we can achieve the normal heating 94%. But if we perform the auto-transplantation for the newly formed socket, the normal heating will be 57%, and we can have a lot of complications after that. So I would like to say transplantation into healed site has poor prognosis compared to the extracted site. So clinical suggestion is early auto-transplantation is the most recommended timing for transplantation. So let me go conclusion. So if you want to achieve the successful auto-transplantation, recommended thing is younger than 40 years old, simple and single root shape with healthy PDL, and early transplantation. Really good results. On the other hand, these things are not recommended. The patient is older than 40 years old, but there is no limitation. So you can do the auto-transplantation actually for the elder people, but you have to tell the patient the success rate will be not so good. And the second one is complicated and multiple root shape with periodontal disease of Donatus. So it's going to be very difficult to extract it when we extracted the multiple root shape. So please refrain from using the multiple root shape and the periodontal disease teeth for as a Donatus. And transplant into healed site of the recipient site. Actually, you can get some okay results still. You can achieve like a 50% success of the recipient site, but compared to the other like extracted site transplantation, the results will be a little bit poor. So you have to tell the patient. And if you can make a treatment plan, if the patient have a pulpous tooth, you should tell the patient before extracting the pulpous tooth. Thank you for watching.
Hello, my name is Kazuhide Noda from Japan. I'll be presenting on the topic of treatment planning in a hyper-aged society. I am 40 years old and I became a dentist in 2007. I have studied a wide range of topics including periodontics, implants, occlusion, and orthodontics. In 2020, I opened a dental clinic specializing in occlusal treatment. It is designed in a relaxing Japanese style for both children and the elderly. In Japanese dentistry, there is an insurance system, but the specialist system is not with widespread. Therefore, I'm aiming to provide comprehensive dental care myself. One of my clinical concepts is precise treatment for a tooth. Minimal intervention, endodontics, and periodontal regenerative therapy. Another clinical concept is a treatment plan that considers the patient is life stage. Dental problems are often not only inflammatory problems, but also force problems are present. The longer the lifespan, the more important it became to control force. MI is not required for every case, but it varies greatly depending on the prosthetic effective condition and especially the age of the patient. In other words, treatment planning that considers the patient's life stage is important, which is also the theme of this presentation. Information control is the basis for the prevention of dental caries and periodontal disease in all age groups. And it is important to consider the patient's life stage when planning treatment for patients with pathological occlusion. In adulthood, it is important to prevent periodontal disease and loss of teeth. In childhood, it is most important to ensure proper oral function and normal development of the jawbone as much as possible. In addition, the possibility of treatment is high in young patients, so we adopt a conservative treatment plan rather than a predictive one. On the other hand, the concept of occlusal treatment for the elderly is contrastive in the elderly. Dental intervention to restore and maintain oral function is more important. Since data shows that people with more teeth and denture wears have a longer life expectancy than these with fewer teeth and no denture. We approach health promotion by restoring occlusion as much as possible. This is my prudential case. This change in the patient's face also shows the improvement in QOL. Next is the case of an overdenture. When the occlusion is collapsed like this, the tooth position and mandibular position are also considered. Pathological and occlusal reconstruction is appropriate. For this patient, we thought it was more important to let him be able to choose as soon as possible than to save his teeth. Thus, we developed a treatment plan with a few retreatments as possible. The occlusion was reconstructed with an implant overdenture. On the other hand, there is also the problem that as people get even older, they stop using dentures. In the field of nursing care, there are problems with these remaining, but the problem with the teeth being removable also bother us. Japan has become a super hyper-aged society, and it is expected that about half of today's elderly people will live to be 19 years old. More than 50% of 80 years old have 20 or more teeth. As life expectancy increases, the gap with healthy life expectancy becomes an issue. What can we do to lengthen our healthy life expectancy? While there are elderly people who are bedridden with full dentures, there are also elderly people who want a high QOL, which is highly individualized. Was 18 years old and has a fractured lower left six. A partial denture was made for the missing mandibular molar and maintained. However, 5 years later, the patient came to the clinic saying the front tooth had fractured. The patient also appeared to be aging considerably. She said that she did not use the partial denture. The problem is that mandibular molars were missing for a long time, and the mandibular maxillary molars were fractured. Panoramic radiography graphs show marked protrusion of maxillary molars, made of which are pulpless teeth and non-conforming prosthetics. The proper mandibular position could not be determined due to overstimulated muscles. First, a temporary crown was placed on the maxillary anterior teeth to restore aesthetics, and the mandibular anterior teeth, which were occluded, were temporarily modified with composite resin. This is treatment planning. Due to the lack of molar and occlusal instability, the temporary were replaced with temporary mandibular positions. Then digital simulation of implant position was done. Considering the age and treatment period, the plan was to place the implant as far as possible within the existing bone. An implant guide was created based on the digital simulation. This is a panoramic radiograph after bilateral implant placement using the implant guide. As the molars were occluded, final occlusal sampling was done and the diagnostic works up and provisional crowns were made for the final prosthetic. The provisional restoration were placed and the occlusion was evaluated. The final prosthetic was fabricated as there are no particularly problems such as behind sense. The plane, which was also procedurally lowered in cephalo, was plating the mandible located slightly. Final restoration was set. The patient was given a night guard for nighttime glasses, and occlusal adjustment were made during cleaning. Even 3 years after the end of treatment, the prognosis is still good and maintenance is being continued. To fulfill the patient's wish to eat well until she is 100 years old, if possible, because the patient was a healthy elderly person, I set a goal to do the best I could. Conclusion. In occlusal treatment of the elderly, early recovery of masticatory function is more important than preservation of teeth. In many cases, a holistic approach is necessary to minimize the need for treatment. The quality of life determined by patients has increased, and prosthetics are increasingly being considered for long-term prognosis in the elderly. As life expectancy increase, it is necessary to respond to individual needs.
Thank you for watching to the end. We sincerely appreciate the many participants. We do this kind of work every day. Please post your thoughts on the Facebook group page. We would like to organize the next meeting on March 20 next year. We would like to participate in your webinars and meetings as well. We look forward to meeting you face-to-face someday. Let's continue to work together for the future of dentistry. Thank you very much. 終わりで。
スクショしたんだ。
いい？OK です。